This is the phase 1/2 study of a compound called REGN5459, the bispecific BCMA by CD3 monoclonal antibody in patients with relapsed refractory multiple myeloma. The molecule is a bispecific antibody with ability to bind onto BCMA on the surface of the myeloma cells. And the unique aspect of this agent is its low affinity to CD3 on the surface of the T cells. The current issue with bispecific antibody in myeloma includes inflammatory response called cytokine release syndrome, as well as some neurotoxicity that occur when the T cells are engaged with the cancer cells. It causes a lot of inflammation, and in some patients, causing severe toxicity. So patients continue to receive care in the hospital, getting step-up dosing until they get to the full dose. To make the treatment more available to patients, this compound is being developed because it shows itself to have lower cytokine release in preclinical model based on its ability to capture the CD3 at lower affinity. So in this study, there are two portions. The phase 1 portion evaluate for safety profile and to identify phase 2 dosing. For phase 2, we look at efficacy based on response rate. There are 43 patients enrolled to the study. These have to be folks who have active myeloma, fail at least more than 3 prior lines of therapy, including existing agents, the immunomodulatory agents, the proteasome inhibitor, and also CD38 antibodies. As it turned out, over 70% of patients were in fact penta-exposed, meaning that not only they were exposed to the 3 prior classes of drugs, they in fact were exposed to more than one agent in each class. They also had high tumor burden based on high bone marrow involvement of myeloma, and over 30% were age 70 and older. So that represents a more aging population of myeloma patients. So what we learned from the phase 1 portion was that as we were escalating the agent from the lowest dose level of 3 milligram up to the top dose of 900 milligram, as we were escalating, the agent was reasonably well tolerated. There was no MTD identified. And at the top dose, the 900 milligram, there was one patient who had hypoxia, not in the context of the CRS, but it turned out that that patient had COPD and primary lung cancer. So probably not really related to the study drug. The dose that was chosen for expansion was the 480 milligram. Because of that dose, the cytokine release syndrome seemed to be manageable, low grade, and also we had response rate of 100% at that dose level already. So if you would look at the top dose, combining the 480 and the 900 milligram, there are 21 patients that were treated at that dose level. What we saw was that their response occurred pretty early and deepened over time. The median time to response is actually less than a month. And over nearly 80% of patients who responded were projected to continue to maintain their response passing the 12-month mark with a strong response rate that's over 90%. And as I mentioned, the 480 milligram gives us 100% response rate. So we were pretty pleased that by dialing down the CD3 affinity, we in fact did not lose cancer control. So because cytokine release syndrome is a primary feature of this compound, we look at the cytokine release syndrome grading and severity. There were about 80% of patients of that top 2 high doses that still had CRS grade 1. When we look more closely, they seem to just have fever. Only about 16% of subjects actually received tocilizumab in the whole study, and less than 10% received additional corticosteroid. So most patients were just treated successfully with antipyretics, and that fever seemed to subside, allowing them to escalate to the full dose. So now that we have median follow-up of about 9 months, many patients are still in their early journey on this study drug, but we have several that go past the 26-month mark at the last data cut and continue to enjoy remission. Infection is another problem. I think when we treat patients with multiple myeloma who are already immunocompromised, and with this particular group of agents, it lower the immunoglobulin level, lower the T cell function down the road because of T cell exhaustion. It remains unclear whether by having lower CD3 affinity, we prevent the T cell exhaustion or not, and I'm hoping correlative data may help clarify that issue. We see about 60% of patients with infection, and about 30% of them were grade 3-4, which means that they required intervention, including IV antibiotics. Most of these were respiratory tract, and there were some with urinary tract infection. There were 2 deaths from infection from pneumonia and from COVID-19.